enzymes and liver biopsy is normal, the patient is a reservoir for infection. Healthy carrier show absence of hepatitis B E antigen, absence of hepatitis B E antigen, and the presence of anti-hepatitis B E, normal liver enzymes, and low hepatitis B virus DNA. The patient lack of inflammatory and parenchymal features of injury in liver biopsy. Hepatitis B virus, HIV and chronic hepatitis. HIV is frequently or not uncommonly can be detected or can causing co-infection with hepatotropic viruses, especially hepatitis B and C, because both of them transmitted by parenteral route and through contaminated blood product, and there will be overlap of risk factors and symptoms. The changes or morphology of viral hepatitis, or the morphological changes, whether growth or microscopical changes of hepatitis, can be overlapped, whether in the chronic and acute state, whether the reaction is to drug toxicity, called the drug-induced hepatitis, or it is immune hepatitis, or liver infected by hepatotropic virus, and so on. Whatever the virus, so there will be overlapping and similarity of the changes, hepatocellular injury in liver biopsy, and that can be caused by these viruses. In the acute state, there will be lobular hepatitis. Lobular hepatitis, that is cellular infiltration of hepatic lobules, inflammatory infiltration, loss of normal hexagonal lobule or normal liver microarchitecture, ballooning or ballooning degeneration, Kupffer cell hyperplasia, increase in the number of macrophage, hepatocellular necrosis, or apoptosis, or called Castleman bodies, and foci of regenerating hepatocytes after hepatocellular damage, cholestasis, that are plaques or a collection or accumulate or aggregates of biliary secretions in between the cells and within the cell, within the cytoplasm of the cells, and fatty change or steatosis or hepatic steatosis, whether microvesicular or macrovesicular. The chronic features is well-preserved architecture, portal inflammation with mononuclear infiltration, lymphocytes and plasma cells, interface hepatitis in the previous lecture seen, spilling of hepatocytes from the portal tract into the adjacent periportal area, and deposition of fibrous tissue in the portal tract, between portal and central vein, bridging fibrosis and bridging portal fibrosis. Liver cirrhosis, or formation of various regenerating nodules, scarring and laying down of a lot of fibrous tissue. Fine granularity of hepatitis B viral antigen, called ground glass appearance, or due to the assimilation of hepatitis B virus S antigen within the cytoplasm. Hepatitis C viral infection, there is a feature of lymphoid aggregation with the aggregates within the portal tract, ductular reaction, and macrovesicular steatosis are features. So lymphoid aggregate, macrovesicular steatosis, fatty change, and ductular reaction are features of chronic hepatitis C virus infection. This is a diagram, nice diagram to summarize the acute hepatitis, microscopical changes and chronic changes, portal tract accumulation of mononuclear cells, few cells, and ballooning degeneration, swelling or feathery degeneration, apoptosis or Castleman bodies, macrophage hyperplasia, Kappa cell hyperplasia, apoptotic bodies again, and cholestasis, aggregates of biliary secretions in between the cells and within the cells, that is feathery degeneration. These are all of these changes are reversible changes, whereas chronic hepatitis, there is dense or prominent mononuclear infiltrate, bridging necrosis and portal fibrosis and bridging necrosis, followed by bridging fibrosis, which is a reversible process, and is the start of nodular regeneration of cirrhosis, ductular reaction as stimulated by inflammatory cytokines of chronic inflammation, and increase in the number of these ductules are seen as a result of stimulation by inflammatory cytokines. Hepatocyte hepatitis B S antigen or ground glass appearance of hepatocyte due to presence of hepatitis S antigen within the cytoplasm, fatty change, micro or macrovesicular hepatitis in C with associated lymphoid aggregate and ductular reaction. So chronic changes, reversible changes, are bridging fibrosis, which is the start of cirrhotic nodule. اوكي autoimmune hepatitis. طلاب خلينا نطلع حتى نسوي تسجيل جديد للمحاورة، نطلع ونسوي ريكورد آخر. اوكي شباب معايا؟ طلاب اكو سؤال لحد الان؟ Autoimmune hepatitis. As we say previously, autoimmune diseases or disorders comes in clusters, either in the same patient with, or in other family members. So they have a genetic predisposition or hereditary predisposition. The patient with autoimmune hepatitis, as we say, microscopically and morphologically, the changes can be the same for viral, for drug-induced hepatitis, toxic hepatitis, and or even autoimmune hepatitis. Chronic hepatitis, the disease is of autoimmune process or autoimmune background, have a genetic predisposition and association with other autoimmune disease, and presence of certain autoantibodies in the serum, anti-nuclear antibodies and anti-smooth muscle antibodies are detected in the serum of these patients with certain hepatic or certain manifestations of chronic liver disease like jaundice or elevation of serum transaminases or another manifestations. And also they have a response to steroid or immune suppressant therapy. There are two types of autoimmune hepatitis, type 1 and type 2. Type 1 affecting middle-aged and elderly with presence of anti-nuclear antibodies and anti-smooth muscle antibodies, and type 2 affecting teenagers with the presence of anti-liver kidney antibodies. There will be rapid progression or rapid progressive disease or follow indolent course. Either the disease develop rapid progression or rapid progressive hepatitis, chronic hepatitis, or indolent subclinical course, slowly growing, according to many factors and according to the treatment, response to treatment, and according to the immune response of each patient. Plasma cells that are secreting antibodies, immunoglobulin, are prominent and characteristic in liver biopsy. The plasma cells, these are plasma cells with eccentric nuclei, eccentric cartwheel nuclei, are characteristic in autoimmune hepatitis in the portal circulation, in addition to lymphocytes. The liver can be a site for bacterial infection from three main routes: ascending spread from the colonization of the biliary tract or biliary passages by bacteria. It is almost always followed biliary obstructions by a gallstone or common bile duct tumor. Infection ascending in the portal vessel or comes from portal circulation, any focus or sepsis in the intestine, in the bowel, like abscess, complicated appendicitis, diverticulitis, and so on. Focus of infection will be transmitted through the portal circulation to be seeded into the liver, called portal pyemia. This is a complication of gastrointestinal suppurative disease, or it comes from through the blood circulation from the hepatic artery, systemic blood, any focus of septicemia or septic infection, tuberculosis, to the liver in case of miliary tuberculosis. اوكي، اكو سؤال لحد الان شباب؟ autoimmune bacterial infection of the liver. Okay. Non-alcoholic fatty liver disease. This is a special entity or disease called non-alcoholic fatty liver disease. احنا راح ناخذ alcoholic liver disease, and these are the non-alcoholic. There's a special entity called non-alcoholic fatty liver disease. Fatty liver or fatty steatosis or fatty change that are developed in non-alcoholic people. Obesity is the most common cause, diabetes, and so on. It is a common condition of fatty liver in developed countries and patients who are not drink alcohol. The liver may show all the changes that are seen with alcoholic liver disease. In alcoholic liver disease, there is stages for the development of liver disease that are steatosis, which are liver or hepatic fatty change. Steatosis is a reversible process. Hepatic steatosis or hepatic alcoholic steatosis. Non-alcoholic steatohepatitis. Alcoholic steatohepatitis with fatty change, there will be development of hepatitis, filtration by inflammatory cells, and features of hepatocellular damage and injury. And the last irreversible stage is cirrhosis, development of cirrhotic nodule. Here in non-alcoholic fatty liver disease, all these stages of alcoholic liver disease can develop in these people. This is a spectrum of non-alcoholic fatty liver disease. This is the healthy liver can develop reversible fatty change or fatty accumulation. The fatty and non-alcoholic steatohepatitis is also reversible, can be reversed to resolved after treatment or after resolution of the cause. When it is, or it can be passes into cirrhotic liver with a lot of replacement of the hepatic lobules by regenerating nodules and with the development of obstruction of blood flow and biliary passages and features of liver failure. Two types of non-alcoholic fatty liver disease, type 1 and type 2. Type 1 with a genetic predisposition and type 2 with metabolic, in which there is excess ingestion or obesity of food. There will be increase in the adipose, increase in triglyceride synthesis, increase in hepatocellular disease and chronic liver disease, risk of type 2 diabetes and chronic vascular disease. With the excess consumption and obesity, there will be increase in insulin production and increase by the pancreas, and also increase in adipose tissue and increase in muscle insulin resistance, increase in insulin resistance in the muscle and adipose tissue. And so there will be increased the demand for insulin secretion. The pancreas will secrete a lot of insulin without benefit because of increased resistance in the peripheral tissue, increase in fatty acids, and increase in glucose production and by the liver result in type 2 diabetes with accumulation of visceral fat. The development of obesity and insulin resistance is behind the pathogenesis of non-alcoholic fatty liver disease. Insulin resistance, increased mobilization of free fatty acids from the adipose tissue to the hepatocytes and stimulate the synthesis of free fatty acid by the hepatocytes because of increased insulin resistance, and so the body trying to make energy from the free fatty acids. Increased toxic effect and inflammation and inflammatory cytokines in the liver tissue. Non-alcoholic fatty liver disease is a common cause of incidental elevation of serum transaminases, elevation of serum hepatocellular enzymes, and pediatric non-alcoholic fatty liver disease is increased among as the obesity epidemic spread to pediatric age group. Okay. Jaundice. What is jaundice, please? Who can define jaundice? Any idea about jaundice, please?
Accumulation of bilirubin in the blood, non-conjugated.
Yes, as a symptom, it is the yellowish discoloration of skin and sclera, yellowish discoloration of the skin and sclera. The normal bilirubin should not exceed 1 to 1.2 milligram per deciliter, from 0.3 to 1.2 milligram per deciliter. There are two types: unconjugated, that is the indirect fat soluble, and the conjugated, that is the direct bilirubin. The bilirubin is the end product of senescent erythrocytes with production of heme, biliverdin, and bilirubin, which will be combined to albumin, that is the fat water insoluble, and that is and in the liver it will be conjugated with bilirubin conjugation, that is the bilirubin will be conjugated to be excreted in the bile canaliculi and to the common bile duct and the duodenum to be excreted as a stercobilirubin and stercobilinogen and urobilinogen. Any defect of bilirubin metabolism or jaundice appearance, it will be the result from either there is excess. نعم.
دكتورة صوتك يقطع.
صوتي يقطع. ما تسمعني؟ ما تسمعوني؟ تقطع الصوت؟ نعم.
دكتورة صوتك يقطع، ما أدري مشكلة بالنت لو.
احنا نحاول نبعث لكم التسجيل، يعني بنسجل ان شاء الله، وهذا الصوت اذا حاول تكمل معانا اكو تسجيل ان شاء الله راح نبعث لكم اياه، هي هاي المحاضرة نفسها، بس اخاف عندكم سؤال او شيء. There is either excessive bilirubin production, like in what are the causes of excessive bilirubin production شباب؟
دكتورة hemolytic anemia.
Yes, hemolytic anemia. There will be excess bilirubin production. Reduced hepatic uptake. In which state? What are the causes of reduced hepatic uptake?
دكتورة hepatic مثلا hepatitis أو liver cirrhosis.
Exactly. Hepatocellular injury, diseased hepatocyte are unable to metabolize bilirubin. Okay. Impaired bilirubin conjugation. What is the cause of impaired bilirubin conjugation? سامعين بالcongenital diseases of or يعني هذه congenital bilirubin. لا مو gallstone. Impaired bilirubin conjugation, the conjugation of bilirubin with the enzymes. هذه الانزيمز اللي بالهيباتوسايت that are converting indirect bilirubin into direct bilirubin, soluble bilirubin. The process of conjugation here is impaired due to genetic or hereditary deficiency, either absolute deficiency of conjugation enzymes or partial deficiency of conjugation enzymes. هذه Crigler-Najjar syndrome, Durbin-Johnson syndrome, also another disease called that is partial Gilbert disease with partial deficiency or of the bilirubin conjugation enzymes. So these people with this hereditary deficiency or absolute absence of enzymes, they have impaired conjugation of bilirubin with resultant. هذول ايش راح يصير عندهم لحد هنا شباب؟ decrease hepatocellular excretion. لحد هنا impaired conjugation, reduced hepatic uptake and excessive bilirubin production. هذه يصير عندهم direct لو indirect hyperbilirubinemia شباب. direct or people with excessive bilirubin production reduced hepatic uptake, and impaired bilirubin conjugation due to genetic or hereditary deficiency of conjugation enzyme. What are the type of bilirubin elevated in these people?
دكتورة راح يكون indirect أو unconjugated.
Exactly. Yes. عاشت إيدك. ليش؟ لأن here until this stage the bilirubin is unconjugated, indirect, fat soluble. زين. Decreased hepatocellular excretion. هذا شو تقولون عليه direct or indirect? Decreased hepatocellular excretion. Here the defect. وين هنا الديفكت؟ يعني
direct بالconjugated bilirubin.
Yes, the bilirubin here is conjugated, but the defect is in excretion. Excretion يعني وين؟ يعني بالbiliary passages, either
بالreceptor.
لا, excretion. Here the bilirubin is conjugated. It is conjugated with by the effect of conjugation enzymes to be converted into direct bilirubin. And the defect here is in excretion. It is not excreted properly, either due to obstruction, stenosis of the biliary duct, or bile or gallbladder stone, or intrahepatic biliary stones, and so on. Impaired intrahepatic and extrahepatic bile flow, either here also the same. Decreased hepatocellular excretion, also here the defect is in biliary passages. And impaired intra and extrahepatic bile flow, mainly due to gallstone, intrahepatic or extrahepatic common bile duct obstruction, or by a tumor, or by a tumor in elderly people, or stone. Cholestasis. Choli means يعني شنو choli? Choli means bile. Cholecystitis معناها inflammation of gallbladder. Cholestasis means impaired passage or impaired biliary flow, biliary secretion flow, and accumulation of bile, intracellular or extracellular bile accumulation. It is caused by extrahepatic or intrahepatic obstruction of the biliary channels, or by the defect in hepatocyte bile secretion. Jaundice, pruritus, and skin xanthomas are the clinical manifestation. Jaundice and pruritus due to accumulation of bile salts within the skin, and skin xanthomas, cholesterol-rich bile secretion can accumulate xanthomas that are in which they are lipid-rich or with associated foamy histiocytes in the skin. Serum elevated. شوفوا شباب هنا قلنا هذه الالكالاين phosphatase and gamma glutamyl transpeptidase enzymes. These are enzymes of indicate what? Alkaline phosphatase, and especially gamma glutamyl transpeptidase. قبل شوية ذكرنا قلنا ال AST والalanine transaminase والaspartate transaminase are indicators of hepatocellular injury. ALP, alkaline phosphatase, and GGT are indicator of what?
دكتورة disease of bile duct.
Yes, biliary canalicular damage, or biliary canalicular disease. صح. Bile plugs or bile